Hi, good afternoon. John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn on this bright but cold Thursday afternoon. Here we're on location here, but we are happy to invite Dr. Allison Callahan to the hot seat today, and she is going to be talking to us about oculoplastics. Can I get the next slide, please, Allison? So we wanted to make sure folks were aware of our upcoming Lunch and Learns. We are really excited to steal a talk from the APP Grand Rounds and have Megan Grady come next week, talk to us about AFib and AFlutter. By the way, those APP Grand Rounds are the second Tuesday at noon of each month. And if you're not getting those emails or that invite, please contact myself or Amy Israelian. Following that, we have one of our family doctors, Dr. Abigail Love, talking to us about all bodies welcome, inclusive care with health at every size. And then we're going to have Avna Alifas return to us and talk to us about sudden hearing loss. Just as a reminder, all these talks are up on our intranet, and they can be searched that way. Links are here as well as up on YouTube. And you could apply for 1/2 hour of AMA PRA Category 2 credits when you listen to these talks. Next slide, please. So we're really excited to introduce a new financial wellness series brought to you by New York Life Financial Wellness. It's a seminar series. We will be offering 4 unique presentations as part of our wellness series, and they will be hosted by New York Life, obviously a well-established company. The seminars are all virtual. They all will be recorded. And if you're unable to attend, and you can also hear them at your convenience. We will be sending an Outlook invitation for folks. This is a no commitment seminar. There's some great talks in here about financial wellness, and we're looking forward to the first talk on a Wednesday, February 16th. We have designed them to be at 6:30 p.m., thinking you can get home from your office and enjoy them at home. But again, they will be recorded, and you can see the upcoming topics. We're quite excited about this series. If this series is well received, we will think about doing some other series, not just in the financial space. So look out for an invite from me. Next slide. And we wanted to make sure everyone was aware. We've been messaging this for the last couple of weeks, starting last Tuesday, January 18th, or 2 Tuesdays ago now at this point. The Shipley Fitness Center is now open to all NWH employees. All you need is a badge to get into the Shipley Fitness Center. So the excuse of I can't afford a gym is gone. Also, the excuse that the gym is not open when I need it is gone as well. As you can see, they open at 4:30 a.m., stay open until 10 o'clock, and on Saturday and Sunday, 5 to 6 p.m. Please take advantage of this free benefit all the way through the end of May. All you need to do is fill out a health appraisal form. If you have any questions, you can contact Daniel Destin. He or one of his amazing staff over at the Shipley Fitness Center will get you squared away. This is a great benefit, and if it is being used, we will think about hopefully trying to extend it or in some way. So please take advantage of us. Tell us how it is. The Shipley Fitness Center is a great place to help you get through these times. Next slide. And then we want to make sure everyone was aware of our new NWH provider directory. These are available hard copy. They're trifolds. They're awesome to keep on your desktop. Also great to have your front desk staff have. I put these in front of my office staff, and they were excited to have one-stop shopping for all the phone numbers that are needed. These numbers were all vetted by the great work from Audrey Bossi and her team at the Office of Experience and Engagement. Please contact her if you'd like to have the hard copies. Also, there's a downloadable directory, right? There'll be from making rounds that we sent out, and we can also send you that link again. So again, this is a nice place for all NWH provider as a provider directory. It is not a patient-facing document. It's meant for the providers in their offices. Next slide. And that's it for the announcements. Allison, take it away. Thanks for being here.
Great. Thank you so much for having me. To those of you I haven't met, I'm Allison Callahan. I am an oculofacial plastic surgeon, and I recently joined the Newton-Wellesley team back in the fall, and I'm excited to be here, and thank you for the chance to talk with you and share a little bit about what I do and how I might fit into your practices. I am definitely in a niche field, so I often get questions about what it is exactly that I do. So I thought it might be helpful to just kind of go over the breadth of what we do and what things you might see in your practices that I can help your patients with. Sorry for the little pause. We're not advancing here, but hopefully it will soon. All right, we're in business. So I go to two practices at Newton-Wellesley Hospital or affiliated with. I go to Newton-Wellesley Eye as well as Derm-Wellesley. So Newton-Wellesley Eye is a full ophthalmic practice. It sees all things ophthalmology, and I'm well set up there to see medical as well as some cosmetic things. I do also go to Derm-Wellesley, which is a dermatologic practice. They have a great surgical outpatient procedure suite where I can do some surgical procedures and obviously have the full armamentarium of non-surgical toys that we like to use around the face and eyes to help patients with their cosmetic needs. I'm happy to have you reach out to me at any time. My email, my cell are here. Please don't be strangers. If you have a question about a patient or where to send a patient, don't hesitate to ask me. So our field of oculofacial plastic surgery, we do things around the eyelids and the soft tissues of the face, as well as the tear duct system, the lacrimal system, and also orbit, primarily orbital tumors or masses. But today I kind of am just focusing, we have a short period of time, and also I think probably the things you see most in your practices are the things around the eyelids and the face. So I'm going to focus in on that today. Our roadmap for what I was going to talk about. Hopefully I can make you kind of 5 minutes dangerous on a few of these topics. Skin cancers, droopy lids, both a ptosis as well as dermatochalasis. What's the difference between the two? I'm sure you see these words come up in your patient's charts all the time. And then some of the non-surgical things that we do around the eyes, filler, Botox, neurotoxins. If I can have you take away three categories of things that you see in your practices that I can help your patients with, it's probably skin cancers, droopy lids, and cosmetics. So in the eyelids, just a very brief review of anatomy. It's complicated, but can be simplified pretty easily. There are 7 actual layers of the eyelid, but really in effect, we think about it as a group of 2 layers. So there's the anterior lamella, which is comprised of the skin and muscle, the orbicularis. And then there's the posterior or back lamella, which is comprised of tarsus, which is collagen, but it's really the structure part of the eyelid. You can almost think of it like cartilage, but even though it's just collagen. And then it's lined in a conjunctiva, which is mucosa. And that's what opposes the surface of the eye so that when we blink, we don't scrape the surface of our eye. It's really important that you have ample of both the anterior and posterior lamellae in order for the eyelid to function properly. And that comes into play as we think about reconstructions or really any kind of surgery around the eye. So the eyelid's job in life is to protect the eye. It protects it from dryness, it protects it from foreign bodies, it protects it from light. It does that by physically covering part of the eyelid, but it also has glands in it that secrete proteins and lipids into the tear film to help keep it protected, moist, and lubricated. When these things go awry, when the eyelids are out of position, that's when I intervene. So tumors and skin cancers are actually surprisingly common around the eyelids and malpositions. So the lower eyelid can be out of position, the upper eyelid can be out of position, but generally if too much of the eye is exposed, it leads to dryness and the eye can really break down and you can lose vision. If too little of the eye is exposed, well, then you can't see because it's blocking it. So starting with skin cancers, this is a big part of my practice and I love doing these things. Basal cell is the most common kind of skin cancer we see, but we certainly see a good variety of things, squamous, actinic keratoses. We get some zebras, sebaceous, mucoepidermoid, but regardless of what it is, usually gold standard involves surgically resecting that part of the eyelid and then reconstructing it. I do often work in collaboration with a Mohs dermatologist, wherein they'll do the removal and then I do the reconstruction. So this is a great example of that. This woman had this lesion on her lower eyelid. You can see it looks a little suspicious. You know, it's got pearly heaped edges. The contour of the eyelid's a little off, so there's a change in architecture. And probably the most telling thing is that if you look in this segment, there are no eyelashes. So an absence of eyelashes, or we say matarosis, is kind of a big red flag for us that this is actually a malignancy. And sure enough, this was a basal cell. So I reach out to my Mohs friends and we coordinate a time and a day to work together for this patient. This is the defect that resulted from that basal cell. And you can see sometimes it's surprising, you know, how much of the eyelid has to go just to clear a lesion. The good news is clearing it, you know, cures this type of skin cancer. So that's great. So she's come to me like this and she's already cured. So we've already, you know, we've made some progress, but now it's my job to reconstruct that eyelid. So like I mentioned with the layers, we need the anterior lamella and the posterior lamella in order for this eyelid to function properly. We can't just put a free graft on a free graft because there won't be enough blood supply. So in this type of instance where more than half of the eyelid is absent or missing, we actually do a lid sharing procedure. So we borrow the posterior lamella from the upper eyelid. So tarsus and conjunctiva, we're going to take some of it from the upper eyelid, going to leave it connected so it still has its blood supply. And then we're going to plug it into the lower eyelid, put a skin graft on top to make the anterior lamella and let it heal. So this is what that looks like. I hope you guys aren't don't dislike surgical videos too much, but so you can see I've made an incision in the upper eyelid across the conjunctiva and tarsus. I'm kind of holding it up and then I'm going to rotate it down here. So tarsus, conjunctiva is on the undersurface of this photo. It still remains attached to the upper eyelid here. This is going to get plugged into the lower eyelid defect. And then I'm going to put a skin graft on top of it, let it heal. It heals for a month. So about 4 weeks it takes to heal like this. This is a picture of this patient with her, it's called a tarsoconjunctival flap or lid sharing. So it's important to know that these patients won't be able to see fully out of their eye for a month. And then we come back and in a second stage, we divide it. And then we end up with this very happy patient with a great eyelid and a cured skin cancer. So just a brief example. So upper eyelid malpositions is another one of those things where, you know, bread and butter, we see this all the time, and I'm sure you guys see this all the time as well. So, you know, interactive portion of this this presentation, I want you guys to just take a finger and just put it on your eyelid and just push it down to like halfway down your eyelid, and just try to look around and just imagine trying to drive like that, to read like that, to, you know, socialize with your friends like that. It's really, really annoying. And it's hard to do those things. And we've all seen this, you know, we see it all the time, this woman here, with her lid, you know, half down. But sometimes, you know, patients might not realize that it's actually not that difficult or complicated, and it, you know, there's a simple solution to it. I just encourage you to sort of look around, because I'm sure we both see this all the time, all day long. So ptosis, or drooping of the upper eyelid, the most common cause is involutional change. So it's age-related stretching of the levator muscle in the eyelid. Of course, we do have to keep in mind other causes and do an exam to help exclude systemic etiologies, myasthenia, or a nerve palsy. But by and large, the most common, if you look around your waiting room, the most common cause is just aging. The treatment is surgical tightening of that muscle that got loosened. It's an outpatient surgery. It takes about 20 minutes. And the recovery is about 2 weeks, I would say, 1 to 2 weeks. And this is I just put in a picture of a patient, you know, with her droopy lid. And then after surgery, this is about, I think this was actually at about 8 days post-op. So it's a pretty fast turnaround. I put a little asterisk after treatment is surgical muscle tightening, because actually in the last year, there is an eye drop called Upneek. I don't know if anybody's, from the company has reached out to you about it, but so it's a drop that basically stimulates one of the muscles that we can tighten surgically to lift the eyelid. It works really well for this type of drooping eyelid where it's a muscle that's weakened, as opposed to the next slide where we'll talk about extra skin. It is not covered by insurance. It costs about $150 a month for that type of eye drop, but it is a non-surgical alternative for those interested. Ultimately, most patients that I do prescribe it, ultimately they usually end up coming back wanting the definitive fix, but it is a good alternative for some patients. So as opposed to a muscle being weak, like we saw, and you can kind of see what that looks like in this picture, the other most common kind of droopiness in the upper eyelids is dermatochalasis, which is extra skin on the upper eyelids. It certainly can be visually obstructive when it's severe, and I've put a picture of an example of this down below. You can see this gentleman literally has so much skin, you can't see out from his eyelids. More often, this ends up being a cosmetic issue. In other words, it doesn't meet the severity of the thresholds that our insurance companies set forth as being medically necessary. And I'll kind of talk about that a little bit too. But in either case, we correct this surgically with a blepharoplasty surgery. So you can see both patients respond well to that type of intervention. And this is kind of where our field in the gray zone between where we go from medical to cosmetic comes into play. So I thought I'd transition over to some of the more cosmetic things that we do. In surgically, our bread and butter surgeries for cosmetics in the lids are upper and lower eyelid blepharoplasty surgery. That would be the same type of surgery on this patient where we're removing extra skin from the upper and or lower eyelids. We do some non-surgical interventions as well, like I mentioned, using neurotoxin like Botox, filler, and lasers around the eyes and eyelids. Aesthetically, changes that happen with age that are very common. We lose the elasticity in our skin everywhere, including in our eyelids. Our brows in general descend over time, and together that leads to this hooding of the upper eyelids. It can feel pretty annoying having the skin resting on your lid, but it also does age in appearance. In the lower eyelids, we get fat that pushes forward or herniates. It's not body fat, it's orbital fat. It's always been in the orbit. It's just the layer of tissue, the orbital septum, that used to kind of keep that fat back in the eye socket. As it loses its elasticity, the fat can push forward and we see it as bulging. You can also have extra skin in the lower eyelids and looseness in the lower eyelids that kind of all come together to give this puffy appearance, or patients will come in and say, I don't like the bags under my eyes. These are all corrected with blepharoplasty surgery. In the upper eyelids, like I mentioned, it's an excision of skin. I think the surprising thing when I talk to other people not in my field about these types of surgeries, they're usually surprised to learn that an upper eyelid blepharoplasty surgery, it's actually a relatively, it's a short procedure. It takes about 30 minutes. We can do it in the office. It has a relatively short downtime. So it's a little bit more approachable, I think, than people have in their minds. We do sometimes do it in the operating room, but can also be done very safely in a procedure room that's set up well. The anesthesia is local infiltrate. Sometimes I have patients take an Ativan if they're nervous. And in the operating room, obviously the sedation is IV. Recovery, I usually tell patients 1 week of no exercise, couple weeks for bruising and swelling to go away. You can see this is the, I've marked out here the planned surgical excision. I always check this with a pinch test with forceps. You need some extra skin in the upper eyelids to be able to close the eyelids comfortably. And that's where I think it's important to have a good understanding and to have seen, I see a lot of the flip side where, if someone isn't as well versed in the eyelids, maybe they've taken too much and they've run into problems. So I do think it's helpful to come from a background where you're starting with eyes and understanding, what are the limits around the eyes of what you can do surgically, but still get a good improvement. In the lower eyelids, it's a little bit more involved. Lower eyelid blepharoplasty surgery takes about an hour to perform that surgery. It's done in an operating room. I've put a picture up of this is a transconjunctival approach. So from the inner surface of the eyelid. I think most oculofacial people probably prefer that approach. It avoids some of the complications of surgery taken from the front surface of the eyelid. So you basically open up the conjunctiva and the septum that I mentioned to tease out the fat pads to be able to remove them. Anesthesia in this case, personally, I prefer patients to be asleep for the surgery. You can see I'm tugging on the lower eyelid a little bit. That's uncomfortable. The fat pads are kind of uncomfortable. And when patients are uncomfortable, it leads their blood pressure to go up. They might bleed a little more. The surgery becomes more challenging. And I find patients who are under IV sedation for this procedure often end up getting more anesthesia just trying to mitigate that discomfort relative to if they just were asleep. So, but both are options. Recovery is similar: 1 week, no exercise, heavy lifting, 2 weeks for bruising and swelling to go away. The outcomes can be really profound. You can see this patient I showed you before, and it's very natural looking. It just restores patients to what they used to look like, before these changes happened. It's not making them look like a different person, and results can be quite good. So I've talked a lot about surgery. What about non-surgical things that we do? Because certainly, we do have a lot of patients who come in looking for what they can do that's short of surgery. So fillers, probably a lot of you are familiar with them already, but those not. They're gel-like substances, and they're injected under the skin to restore lost volume. So as opposed to the surgeries where we're kind of, reductive, we're removing things often, fillers replenish lost volume. So there are certain areas around the eye that are very common to lose volume. And those areas in the upper eyelid, sometimes we lose volume in the superior sulcus. So you can see this patient here, she's young, but you can see she's asymmetric, her one side to the other. And she's lost some volume here in her upper eyelid, which could be replenished with filler. Interestingly for this patient, it sort of depends which side she prefers, what you would do. If she prefers this side, well, then you could do a blepharoplasty like you saw in previous photos and remove some extra skin to match the side. If she prefers this side, then you would replenish a little bit of volume to fill out some of the skin to help match the other side. In the lower eyelids, and this is probably the most common area around the eyes to inject filler, is into the tear troughs. We do all tend to lose a little bit of volume right here. That it's accentuated when you also have fat that pushes forward right next to it, sort of a mountain and valley effect. But we do tend to lose volume here, and filler can be injected into that area to smooth the transition from the lid to the cheek. It's a delicate area. There are some vessels around there you have to be very careful of. And I think it's helpful to know the anatomy well. So who's a candidate for filler as opposed to surgery? Surprisingly, it's actually fewer candidates are, there are fewer filler candidates than people who are probably getting filler. So it's patients who have mostly hollowing, very minimal fat prolapsing forward, and have very good skin tone that can support the filler that we're injecting under it. So it tends to be a younger patient, patients in their 20s to 40s, maybe 50. That patient I showed you before is kind of with the puffy lower eyelids. It makes sense. There's no amount of filler that you're going to put next to it to mask that puffiness. And that's an extreme example, but that does relate to patients who even have just a moderate amount of fat herniation. putting in filler next to it is really just going to make them look a little bit puffier, isn't going to solve the problem. They would be better off with surgery. But this patient's a great candidate for filler. She has mostly hollowing. She has a little bit of fat herniation here on the left side, not as much on the right. And she has nice, good skin tone. So she did great with filler, and you can see the difference it made for her. We do also use Botox. I'm gonna, just because I know we're sort of nearing the end, I will try to not spend too much time. This is kind of household name is, you know, Botox is, but there are other neurotoxins, Dysport, Juvia, Xeomin. They all have the same mechanism of action and work very similarly. They have different proteins associated with them, so they can diffuse differently. But the average person isn't going to notice a big difference amongst the different brands. Cosmetically, it lessens dynamic wrinkles, rigidities that happen with facial expression, and it prevents those rigidities from becoming permanent. So if you make an angry, expression over and over and over, those wrinkles are going to eventually become permanent. Patients often, when if they first start approaching neurotoxins, they're worried they're going to look fake or frozen. If you're injecting the right amounts in the right places, it really does not do any of those things. It looks quite natural. So I just put a quick example. This patient, before injecting her, you can see she's got, good frowning wrinkles, some crow's feet, and some lines in her forehead. And then afterwards, this is after we've injected her. So, yep, good. So she still has some residual action, which is what you want. You want to look natural. So she still has some residual action, but none of those rigidities that she had before. As promised in my title, yes, we transfer those skills of, neurotoxin, fillers, laser. We do treat the lower face as well, gummy smiles, lips, nasolabial folds, and chin definition, and a variety of other things. And I will just kind of close it out because I know I'm running out of time. So just a reminder of, the sort of categories of things that we do see all the time that I'd, happy to help you with in your practices and with your patients: skin cancers, droopy lids, whether they're upper or lower, and then cosmetics. Again, I am at these two locations affiliated with Newton-Wellesley Hospital. Newton-Wellesley Eye, which is an ophthalmic practice. Happy to see medical as well as some cosmetics there, and Derm-Wellesley, which is primarily a cosmetic practice for me. Please don't hesitate to reach out to me by email, by cell, however is best for you. And if you have any questions about patients, I'm happy to help.
Thanks, Allison. Before we let you go, we want to make sure people know about the Wednesday morning medical grand rounds, 8:30 this week. I believe we have Dr. Angela Fitch talking about bariatric medicine. So that should be a great talk. That's put on every Wednesday morning. And of course, we'll be back next Thursday. Allison, one of the things we get as primary care docs before we let you go is a lot of our patients ask me, is it going to be covered? Will insurance cover it? Do you do initial consultations on them that they can come and talk to you to see if it's covered? Or how does that work with your practice? Okay.
Yeah, absolutely. I would direct that to Newton-Wellesley Eye because it involves can involve visual field testing and equipment that I have over at that practice if we're trying to see whether it's medical or not. But absolutely, yeah.
And are there different rules for the government payers, Medicare versus the private payers? Do the private payers have a better shot, or they're
actually all pretty similar. They have pretty similar criteria, which are many, but yes.
Okay. Well, thanks again. I hope everyone gets to know Allison here. Thanks. Welcome to the community, Allison. And thanks for coming on a Thursday. We'll see everyone back here next Thursday. Hope we have another exciting weekend of NFL like we had last weekend. And we'll see you back on Wednesday morning for medical grand rounds. Thanks, everyone. Have a great day.
Thank you.